Good morning. My name is Karen Oakes. I am a nursing student at the University of Texas at Arlington. Um, I am taking Nursing 5319, which is Advanced Pharmacology. The presentation is in partial fulfillment of the requirements of the Master's in Nursing Education. My professor is Linda Grand, DNP, APN, CPNP, PC. Today is February 12th, 2020. I wanted to preface my presentation to acknowledge that this is an expansion of the previous topic, which also focused on capsid or methylxanthines in our snippet. The purpose is not only to review the pharmacological mechanics of capsid, but to give an understanding as to the effectiveness of the medication in its treatment of apnea prematurity and expected prevention of the occurrence of chronic lung disease. I will give some information on chronic lung disease because it is a common diagnosis in this patient population, the preterm infant. The information and learner expectations have been provided each participant prior to the course presentation. They're encouraged to review the readings and media information prior to the class. Also encouraged to complete the pre-assessment tool prior to the class. At the end of the presentation, about 60 minutes, the learner will have an understanding of the significance of AOP, or apnea prematurity, and the occurrence of BPD, which is bronchopulmonary dysplasia, actually, or known as chronic lung disease, in the preterm infant, born typically at 33 weeks or less. And then at the end of the presentation, we'll also manage the post-assessment tool, but we'll do that as a collaboration. My objectives, hopefully, will be recognized as evidenced by the learner's ability to recall maternal and infant risk factors, making correlations to the pathophysiologic process. Verbalize understanding of the mechanics of methylxanthine, make correlations as to the management of AOP and the prevention of BPD with the medication, and then show the ability to transfer their knowledge into patient care, providing best practices. I also did include information on patient care standards. There are entities that establish these standards for us and patient care guidelines to try to encourage us to provide best practices for our parents, our patient population. I did actually provide a full list of resources, including a couple of very, very informative videos that I would expect that the participants would watch prior to the class. We have to think globally when it comes to premature babies, in the sense that baby born at or less than 36 weeks is immature in all body systems. Well, that also includes the central nervous system. The central nervous system actually controls our breathing. So if you have an immature brain or immature nervous system, you're likely to have immature breathing patterns as well. Premature infants are subject to have apnea, which is basically a cessation of breathing for 15 to 20 seconds or more. Actually, 6 or more in a 24-hour period warrants noting and perhaps some intervention on our part. These apneic episodes can be tied to a few factors. Of course, the central nervous system immaturity, which causes central apnea. There can always be airway obstruction also. And a lot of times this is just basically because the baby's not positioned properly. The optimal airway positioning isn't there, so we kind of fix that part. Or you can have a combination of both. You have a preterm baby, they get a head lag, and obstructs the airway. All of those can come together to cause the baby to have apnea. As a provider, it's our responsibility to actually facilitate breathing, to provide the support that the baby needs to get them through this. Very often it's just a little tactile stimulation that's required, or repositioning of the baby. It actually facilitates the breathing or brings the breathing on. I mentioned before, when you have a baby with 6 or more episodes in, say, a 24-hour period, we kind of rethink our process. with those babies. Should we begin treatment with Capsid or the methylxanthine early? Or should we, or even prophylactically before the baby has any apnea bradycardia or apnea spells, then we do consider caffeine citrate. Caffeine is a central nervous system stimulant. Basically reminds the baby to breathe. And what's important in that, if you don't have apneic spells, we don't actually have to provide you with more invasive procedures to keep you breathing, such as endotracheal intubation or putting the baby on mechanical ventilation because the baby stops breathing. So what we try really hard not to do is intubate the baby, because that process in itself, it helps the baby but hurts the baby. Mechanical ventilation can cause damage to the baby's lungs. There's inflammation that gets in there, and then of course with healing, of course there's scarring, and it just kind of could make for a lifetime of concerns in this child. Caffeine is the most commonly methylxanthine provided in the NICU. Remember that it stimulates respiratory centers in the brain, specifically the medulla. It increases sensitivity to CO2. It increases skeletal muscle tone and diaphragm contractility. It stimulates the CNS and the cardiovascular system. It enhances peripheral chemoreceptor activity, which actually help to terminate apnea and initiate normal breathing. It also may have some mild anti-inflammatory actions as well for the immature lung. Methylxanthines, the pharmacokinetics, CNS stimulant, again, bronchial smooth muscle relaxant, cardiac muscle stimulant, has some diuretic properties. There's complete bioavailability, whether the medication is given IV or PO. Peak plasma levels are within an hour. There's no first pass metabolism, basically meaning the baby gets the medicine and it's doing what it's supposed to do, probably within an hour. Biotransformation occurs in the liver and it's excreted by the kidneys. Again, with capsid, we're going to talk a little bit about dosing as a treatment for AOP, or even to facilitate extubation if we did have to get that far with it. The loading dose is 20 milligrams per kilo times 1 IV over 30 minutes. 24 hours after that, we give a maintenance dose of 10 milligrams per kilo over 30 minutes again. And the timing may be unit specific, but in our unit, we give it over half an hour. Caffeine treatment typically runs till the baby is 34 to 36 weeks post-menstrual age, or if the baby seems to do kind of well without it. Just for this, on a nursing standpoint, if you have to give Capsid IV, it is compatible with TPN and heparin, but is not compatible with Lasix. We always want to be mindful and observant for signs of toxicity in the baby. Little ones will actually show tachycardia, heart rate above 160. We have a policy to not give Capsid if the heart rate is 180 or above. The baby could have some jitteriness, feeding intolerance. Seizures are also something to be mindful of, although I've never actually observed seizures in a baby from caffeine toxicity, thankfully. Okay, so I'll give you a link to the objectives. The focus has been on a specific patient population, the preterm infant, identifying risk factors and vulnerabilities of this population, defining an innate process, which is AOP, the management of AOP, focus on the potential to prevent the secondary but significant disease process, CLD, and its long-standing consequences. We have included pharmacological options, mechanics, and correlations to this disease process, drug safety and precautions, and the importance of patient care standards and guidelines. So thank you. I hope you enjoyed my presentation. Bye-bye.